Dear colleagues, ladies and gentlemen, a pleasant afternoon to all. Since the beginning of this year, the world has been confronted with COVID-19, a new respiratory disease which knows no boundaries, no age, no gender, no color of skin, no racial rank, no religious beliefs, and no political affiliation. Everybody everywhere had to adapt to new ways of living and new ways of doing business at home and in public. From early on in this pandemic, it became clear that the etiological agent responsible for COVID-19 is genetically related to other known viruses of public health significance, named SARS-CoV-1 and MERS-CoV, both of which belong to the family of coronaviridis. For this reason, the new virus, initially known as 2019 nCoV, has now been named SARS-CoV-2. Short after, WHO issued guidelines for the classification of the new disease, both in terms of morbidity and mortality, to ensure standard reporting within and between countries and to properly account for the contribution of COVID-19 to national and global burden of the disease. Today, we have invited experts from PAHO and CARFA to share the latest information on ICD-10 coding of COVID-19 mortality and to answer any questions you might have on the WHO guidelines. I will moderate this session and count on the participation and cooperation from everyone to make today's event successful. Without further ado, I would like to invite our first speaker, Dr. Sariso, who's going to give us the opening remarks for this session. Over to you, Dr. Saiso.
Good morning, everyone. I'm Vilma Gavriszewski, and I will give some few words as opening remarks on behalf of Dr. Saiso, but Dr. Saiso will join us later. He is in another meeting right now. At first, I want to thank you, the PAHO Office for Barbados and Eastern Caribbean countries for organizing this important meeting. And I want to thank you everyone for participating. In the context of the COVID-19 pandemic, to count on high quality and timely information is essential. And the role of the health professionals are crucial to register the disease, to take care of the patients, and to implement prevention measures. Taking in consideration the need of standardize the register of COVID-19 cases in morbidity and mortality, WHO and PAHO released the new emergency codes. So we are going to talk about these new emergency codes and also about the correct filling of that certificate. Thank you, everyone, and have a productive meeting.
Yeah, thank you, Dr. Vilma. I will not retry your surname, even though mine is also difficult. Yours, I think, is a bit difficult for me. All right, so yeah, thank you very much for the opening remarks on the behalf of Dr. Saiso, who will be joining us anytime. So we are moving to the second item on the agenda, which is going to be your presentation on international orientation for certifying and coding COVID-19 as cause of death. You have the floor, Dr. Vilma, for your presentation.
Thank you, Jean-Marie. As I said, my name is Vilma Gavriszewski, and I'm a health advisor. I'm an advisor for health information and analysis at the PAHO. The objective of this presentation is to share with you the main aspects of the international orientation for certifying and coding COVID-19. These orientations can be adapted. They are recommendations and can be adapted or adjusted to the reality of the country. And also, we are going to focus on mortality in this session, but these recommendations, these orientations are also can be also applied to morbidity. As I said before, high quality information is more needed than ever. This is a new disease. Fortunately, our understanding of COVID-19 is growing as we learn more about the disease. But we have also, in fact, we have also some gaps to address related to increase the knowledge of this new disease. In this way, death certificate data is essential to identify who is dying, where they occur, and associate the medical conditions. Death certificate data provides also evidence to support preparedness and response, design policies and research, and also evaluate the strategies adopted by the countries. Next, please. Here, we can see some issues that we found in many countries about the underreporting of deaths. Some of them are common for other diseases, but for COVID-19, we have some specific one. Incorrect filling of death certificate is one of them, and in some cases we don't have much information about the disease. We don't know it's a new disease, so we are unsure about how to correct filling the death certificate. Some professional has a lack of knowledge of the concept of the underlying cause of death. For COVID-19, in many countries, we are seeing deaths, in the increase of deaths at home. So some medical doctors don't know how they don't have much information about these deaths. Regarding the availability of laboratory tests and different reporting standards, in fact, these affect mortality, but also affect morbidity. So the international orientation enable COVID-19 mortality to be measured in a comparable manner. The next one, please. So to standardize any register, we should assure to count the same thing. In that way, we need to have a definition and a code. This is the WA definition of a death due to COVID-19. This definition is available in the WHO website and the PAR website. A death due to COVID-19 is a death resulting in a clinically compatible, probable, or confirmed COVID-19 case unless there is a clear alternative cause of death that cannot be related to COVID disease, for example, trauma. And I think our colleague Angela Hintz will explore more this definition in examples. There should be no complete period of recovery between COVID-19 illnesses and death. A death due to COVID-19 may not be attributed to another disease, cancer, and should be counted independently of pre-existing conditions that are suspected of triggering a severe course of COVID-19. The idea is there are some people can die from COVID-19, but people can die also from another disease in the course of the COVID-19. The next one, please. In practical terms, if COVID-19 is reported to be a cause of death, this should be recorded in the death certificate as the underlying cause of death. Lab tests should be conducted if possible. If not possible, you can register also this case as probable or suspected case. In general, it's best to avoid abbreviations and acronyms in that certificate, but COVID-19 is an ambiguous and it's okay to report. Pre-existing conditions that may increase susceptibility or exacerbated disease should be reported in part 2, because this is another aspect of the disease that we are learning. There are comorbidity can increase the risk of a patient of COVID-19 dying. Next, please. Here, regarding the codes, we have emergency codes. It was first released 3 months ago, I think, for COVID-19 disease. U07.1 is an emergency code for COVID-19 when the virus is identified. Or in other words, is confirmed by laboratory testing. U07.2 is for a COVID-19 when we cannot have the confirmation, or the lab test was not carried out, or the lab test was incomplete. Both U07.1 and U07.2 may be used for mortality coding as cause of death. The next one. This slide just shows us the same codes, but in ICD-11. First, because at global level, we have some countries that has adopted ICD-11. And also because now we don't know how long this disease will last in our countries. The next one, please. Since the notification of the first cases of COVID-19 7 months ago in our region, as I said before, we have advances in scientific knowledge about the source of infection, the pathogenesis, about the virulence of the virus, about the effectiveness of prevention measures, diagnosis, and clinical management, among other aspects. However, and also we have evidences of complications in the respiratory system, cardiovascular system, neuropsychiatric manifestations, among the others. And these some complications we didn't see in the beginning of the pandemic, and now because of the number of cases we are seeing. And in August, last August, PAHO has released an epidemiological alert about complications and sequelae of COVID-19. And there are very interesting information in the link below. However, there remain several gaps pertaining to these post-COVID conditions that still require contribution from the scientific community, including medical doctors. The next one, please. So to help us, to help the community scientific and to help all of us to give to register the post-COVID conditions, WHO has released 3 new codes. The first 2 codes are optional codes, but we are encouraging people to register, not the code exactly, but the personal history of COVID-19, post-COVID-19 condition. These 2 conditions, in fact, they are released. They were result of a discussion, extensive discussion with experts from all over the world, and these two codes allow the documentation or to flag conditions that occur in the context of COVID-19 for further investigation. The first one is personal history of COVID-19. Is an optional code used to record another episode of COVID-19, confirmed or probable, but the person no longer suffers of COVID-19. The second one, U09 post-COVID condition, is also optional and allow the medical doctor to establish a link with COVID-19. Let me give an example because I think maybe it's more clear with an example. For example, you have a case, we have a patient that recovered from the disease, the COVID-19, and presents at the emergency department with acute myocardial infarction. Now we know that the virus can affect the heart muscle, but we don't know if this patient is this acute infarction is related or not to the COVID, the previous COVID. So we can put the infarction, the acute myocardial infarction, but we also can register the personal history of post-COVID condition. The third one is for the multi-system inflammatory syndrome associated with COVID-19. At first, we thought that it was just for children, but now there are reports of this syndrome in also in adults. We can, the next one, please. Here are some resources for use, and I want to thank you everyone for your attention.
Okay, so Dr. Vilma, thank you very much for your presentation. Even though for the last part of your presentation, the quality of the audio was not very, very good, but at least we were able to follow those slides. So you gave us the rationale for this orientation session of today. You talked about the definition of death due to COVID-19. You provided the ICD-10 codes for emergency use, and you also elaborated on ICD-11 classification and the post-COVID-19 conditions. So for the participants who are online, I want you to keep the questions written down. We are going to be proceeding with the second presentation, and then we have a question answer session after the second presentation so that we can have all the questions at that time. So having said that, I want to invite Ms. Angela Hinz from CARFA to take the mic and give us her presentation. Angela?
Thank you very much. Good afternoon, everyone. I'm Angela Hines. I'm a Senior Technical Officer at the Health Information, Communicable Disease, and Emergency Response Department of CARPHA, Caribbean Public Health Agency. And today, I'm going to give a little bit more insight into the correct completion of a medical death certificate and the selection of the underlying cause of death. Next slide, please. So we're going to look at the guidelines for completion of a medical certificate. We'll go into the coding and some examples of using the COVID-19 codes and with respect to COVID-19 deaths. And also we will just, look at a few reminders at the end of the presentation. Now, as I go through the presentation, I want you to bear in mind we have a mixed group of people with us here today. Many are physicians, yes, but the many are, and many are also coders. Some have been completing death certificates, and so they understand the ins and outs, and some have not. So bear with me while I go over some fundamentals, and sometimes I will branch into areas that neither group may know, but bear with me as we go along, as I just give you a tip of in terms of the information with respect to really completing good completion of medical death certificates, and also to some of the coding that goes into the process. It will also to give both sides an idea of how important both their jobs are in terms of really giving us accurate information so the correct cause of death can be ascertained. Next slide, please. Next. So the physician's role in death certification, and that is to provide a medical opinion on cause of death. That is an etiological description of the order, the type, and the association of the events resulting in death. And so the physician's role is extremely important because in essence, it's the source of the information that we are going to use all along the process and finally to the end. Next. The one must indicate the course of events, decide which condition is directly responsible for death, and determine what antecedent conditions, if there are any, give rise to the immediate cause. Next. And here's a sample that most death certificates across the region or across the world have. They have at least, and this is the part I'm going to focus on, which is the cause of death section. Yes, the rest of the certificate has a lot of other important information, which would be a lot of the demographic and some of the other risk factor related information. But for the purposes of this presentation, we're going to focus on the cause of death section, which is a section that the physician completes, and it's a section that the coders are going to use in the main, because there are some bits of information outside on the form that they will use to actually determine the codes that they will use for this particular certificate. Next. So all the certificates would have a part 1. And in this section, an entry must be placed on line A. This is the immediate final cause of death. Then lines B, C, D are due to or a consequence of. So you're going to report what gave rise to the line above by asking what caused this condition. And then the underlying cause is the cause that you're going to place at the last line of entered conditions. And it should be that condition that initiated all the conditions above it. Next slide. We want to consider when writing these conditions, the mode of dying is uninformative. For example, if you put things like natural causes old age, senility, cardiac arrest. Because if you say cardiac arrest, there's so many things that result in cardiac arrest. So it really does not give us enough information to work with, for example. You need to report as accurately and precisely as possible. So, for example, in the case of COVID-19, which is that we'll be discussing today, you need to indicate, for example, not just saying COVID-19, but saying it's been laboratory confirmed or test positive, as in the case that we are seeing here. And then you need to note that the underlying cause of death can terminate at the immediate cause of death. Yeah. So as we see here in the example, we would read it. The acute respiratory distress syndrome was due to pneumonia, which was due to the COVID-19, and that was confirmed. Or if you want to read it another way, we could say, because of COVID-19, the person developed pneumonia, which then resulted in the person developing acute respiratory distress syndrome and dying. Next. Important on the death certificate, and I know this is something in the region that we really don't use this section of the death certificate, which is the time interval. And yes, there are some countries where the time interval is almost even lost on the certificate. But I mean, we've been working with countries to try to include that aspect of it and to encourage our physicians to complete it where they have the information. We recognize that sometimes you're presented with a deceased person for which you have absolutely no information. They were not your patient, they were not at the hospital previously, there are no medical records, but something happened in a different location, they brought them to the hospital, they've died on arrival, and you are placed in a position where you need to report. And yes, we understand in those cases, you really may not have the information. But when you do have the information, or when you have gotten some information from the family member who has brought them in, please include it all, because it actually does make a difference into how we determine really what was the final cause, what was the initial cause of death of the person. So the time interval between the onset and the death is really important. It provides a useful check of the sequence of events, for example, because we don't expect a condition to have generated another condition which was a shorter period before the condition with the longer. And I'll give some examples as we go along. It provides information on the duration of illness in certain cases. So it tells us if it's something very long-term, over the years, it was chronic, or whether it was very short, more immediate in nature, because all those things will influence how we determine what was that underlying cause that started the train of events. And you heard me repeat that a lot because I want it to sink in, and I want you to remember that when you're writing that certificate, that ultimately from a statistical point of view, from a public health point of view, we really want to know and what was that cause, what was that condition that led to the series of events that finally resulted in the person dying. Because it's at that initial cause that we are going to point a lot of our resources, our policies, our prevention measures. We need to know what was that first cause. It also allows the correct assignment of the IC code, as I had mentioned before, and then of course, complete where known, even if you give an approximation. You may not know exactly, the family said, okay, he's been suffering from this for years. So then you can say years, approximately, or many years. Or the family might say, it just happened all of a sudden 2 days ago. Then you could say approximately 2 days ago. So even if the patient did mention it to you. Next. So let's take this example. We're looking at, it's the same one that we looked at before, acute respiratory distress syndrome, which was due to pneumonia, which was due to COVID-19. But if you notice at the side where the time interval is, we see that when you look at the onset, the final death, the COVID-19, of course, it was 14 days later that the person died. they had pneumonia for 10 of those days, and the acute respiratory distress syndrome was 2 of the 14 days duration of illness. So you see that progression. You see the 14 days at the bottom. It would not be at the top. It would not be in the middle. You would not have acute respiratory distress syndrome at the bottom 2 days and COVID-19 for 14 days. Yeah. Next slide. Part 2. Now, this is a part that sometimes very often is misunderstood and is not used as often as it should be, because it's another area of the certificate that really gives a lot of more information towards understanding the full picture that would have affected the train of events and the eventual cause of death of the deceased. All other important diseases or conditions that may have contributed to the death, and I say contributed, but did not lead to the underlying cause of death in part 1. So you're putting those things that you think they've contributed, but you don't think they were a direct result. They're not in the direct sequence. Enter in the order of significance. It should present a direct sequence and be logical. So when you're writing it, again, you're ordering it in order of significance. So the first thing you write, it's interpreted by those who read the certificate that was the first thing that you're thinking, has had a greater influence or greater contribution. And then the other conditions, a lesser condition, a lesser contribution. The condition doesn't fit the sequence. If the condition you're thinking of does not fit the sequence in part 1, then consider it for part 2. And again, only if they influence the course of morbid events and contributed to the fatal outcome. So, I mean, as an extreme example, you're not going to put in part 2 if the person had, say, acute respiratory infection, and as we saw in the example before, you wouldn't necessarily need to point out that the person broke their foot 2 years ago, for example. That's an extreme example, but just to show that you want it to be related. Next slide. This is another example where the comorbidities are probably that we know that exacerbate the patient who has COVID-19. This is where you would actually place those conditions. So in this case, again, it's acute respiratory distress syndrome, which was due to pneumonia, which was due to COVID-19. And if you notice in this case, they've put suspected. So they've, again, clearly, they didn't just say COVID-19 and leave it up to everyone to try and figure out, was it suspected? Were they able to do that lab test? Is it confirmed? No, they've identified straight away it's suspected. And then in the part 2, they've entered the other more comorbidity there. So, for example, the coronary artery, diabetes, and obstructive pulmonary disease. And if you notice, they've also indicated the time period. Again, the more information, the better. It's good, yes, for the coding, but it's also good for the researchers who are going to be coming along, as and they are there as we speak, looking at the information and trying to really understand more about this unknown COVID-19. And bear in mind, everything that I'm telling you here applies to all the other conditions that you're going to come across when you actually, and situations you're going to come across when you are completing the cause of death or certificate. Because again, especially in terms of any of the conditions that a lot of research is going into, all this information adds to the understanding of the disease. Next. Some other concerns we note here. Persons with COVID-19 may die of other diseases or accidents, and such cases are not deaths due to COVID-19. So again, the onus here is on the physician here, the attending physician, to really sort through all the information they have at their disposal and to really give their medical opinion as into whether they really think the COVID-19 presence of COVID-19 really impacted or was the result or caused the death of this particular patient. And we'll see a couple of examples coming out. In case you think that COVID-19 aggravated the consequences of the accident or the situation, you may report this in part 2. Yeah? And that's where part 2 comes in. And please remember to indicate the manner of death if it's an accident and record it in part 1, the exact kind of incident or of external cause. So this is just a little sidebar here on external causes of death in terms of accidents, etc. Because this is the area where very often they just put motor vehicle accident and they don't really, and nobody gives any details. And yes, I understand that very often as the physician, attending physicians, you don't necessarily know the detail. But should you have that detail, you can actually put some of that added information here in when you actually complete the death certificate. Next. Sorry, go back one. Yeah. So this is an example here where you know the death may not was not identified by the physician as a COVID-19 death. So it was a person who had a heart failure, and this was due to a myocardial infarction, and that is the underlying cause of death. They have, however, put in part 2 that the person was diagnosed with COVID-19 also. Yeah. So the clinical illness and sequence events leading to death may indicate that even in the presence of COVID-19, a person dies due to other conditions, as we've seen in the example above. Next. So let's look at the coding of these deaths, COVID-19 deaths. So as Vilma mentioned in her presentation earlier, and then again I mentioned it earlier and I'm re-emphasizing it again, the underlying cause of death is that the disease or injury that started the train of morbid events leading directly to death, or the circumstances of the accident or violence that produced the fatal injury. And so the UC here is the primary target for the disease prevention and control, which we mentioned earlier. Vilma mentioned it, and I mentioned it again. It's really what we are going to use for primary target and disease prevention and control. Next. So the coder's responsibility to assign the correct ICD-10 codes to all causes of death listed on the medical certificate of death, use a number of rules and guidelines that have been standards that have been established by WHO ICD-10 group, and use these rules and guidelines to correctly select the underlying cause of death. The coded conditions are only as accurate as what has been written on the certificate. Next slide. So just before I go into this slide, can you, Brenda, can you just go back a slide? Yeah. Just to touch on a note. So the coders are responsible for coding each of the conditions and then ultimately determining the underlying cause of death. Now, there are some instances where the underlying cause of death that is finally determined may not necessarily coincide with what the physician has written. And again, I just want to make that distinction that when a different code has been obtained or determined, it is not in any way questioning what the physician has actually identified. The death certificate as completed by the physician is the legal document. The coding and the rules that are used by coders and the final underlying cause of death that is determined, that is for public health use, for policy, for interventions, etc. So if you see something different because of where you sit, and please don't think that somebody, some upstart is questioning what you're doing and has actually saying that you are not right. And don't let anyone also tell you in terms of based on what as a physician you've identified as a sequence of events, question it and say, well, we saw a coded form that said the person died of something else. No, what you have written is what you are going to stand by and what is going to stand and what is going to be questioned, not what the coders do. Because the purpose of that information is for statistical purposes, it's for prevention, policy, guidelines, it's for being able to fine tune and target more precisely how public health responds to the health of the country or of its nation, of its peoples. So please, when we continue to show you a little bit more, again, we really value and we depend on what you have entered. And so the more accurate, the more details you give, it's the more precise that underlying cause of death will be and the use of that information would be. So your role is really very important. And I say this, and I'm putting in a plug for my coders, because sometimes there may be information on the certificate that are not clear because of writing, because of sequencing of events, or because of, for example, if they see COVID-19 and they don't know if it's lab confirmed or if it's suspect, and they don't have access to the information to be able to confirm that, they may call and ask. But please recognize that they just want to do their job more effectively and more efficiently and more accurately. And so they just really want to be more accurate in terms of their coding. And so I'm pleading that you be more patient with them when they ask information, because it's part of their job. And they're not questioning your decision or what you have written. Next slide. So I brought this slide here, and I know Vilma has already touched on it. And I brought it now. How should I say? These are the additional categories to document or flag conditions in COVID-19 patients. The first two here, and this was the last part of Vilma's presentation that she went through. The first two really have been identified by WHO to flag certain conditions, again, for research purposes and better understanding the whole sequence of the disease. Because as you know, it's all new and we're discovering more all the time. So the 08.9, which is personal hit, the first two, the U08.9 and the U09.9, again, those are for conditions, these are for the post COVID-19 patient. Again, these codes are also used for morbidity coding. So it's for record, the medical record section, not necessarily for mortality coding, but for morbidity. But it also is identifying that the importance of the information that you capture both on your within your medical records, be really very specific. Because then this is a time when we will pick up certain information. If we see personal history of COVID-19, that U08.9 will be included. Yeah, and the U10.9 is for the multisystem inflammatory syndrome associated with COVID-19. Next. So the ICD-10 codes for COVID-19, again, Vilma has gone through this, so I won't go over them, but just to note that these codes again, they would be more finely tuned when you actually say whether it's clinical probable or suspect. To my coders, this is one situation where from a mortality perspective, there is a code for what we would say the virus, the clinically and epidemiologically diagnosed, probable, and suspect. And we want you to code to the fourth, meaning U07.2, and not just the U07. Because of course, again, if you do U07, we don't know if it's been confirmed or not confirmed, etc. Next. With respect to the COVID, a special note for COVID-19. So COVID-19 is not considered, I think Vilma did go over this, said that COVID-19 is not considered as a deuter or an obvious sequence of anything else. An analogy of this would be the same that we do for influenza, right? So in essence, you won't get that you have acute respiratory syndrome, and that was led to COVID-19. That just doesn't happen. So that's just an example of what we mean by it's not considered as a deuter or an obvious sequence of. Further, there's no provision in the classification to link COVID-19 to other causes of modify its coding in any way. So again, this is to the coders that are listening this afternoon. You won't find modification rules related to COVID-19. Nothing's going to be modifying COVID-19. Next. I give this example just to give our physicians an example of how a case may present and how a certificate could be written. So they presented to the emergency department with these particular symptoms, and then upon examination, they discovered there's febrile, hypoxic, and moderate respiratory distress, and a number of other things. Testing of respiratory specimens indicated COVID-19. Eventually, they were admitted to ICU, and despite aggressive treatment worsening, respiratory acidosis, cardiac arrest on the day 3 of admission. So this is how next slide. And this is how this would be presented. It was from the physician's perspective, it was acute respiratory acidosis was immediate cause of death, and that was due to the COVID-19. And what they've put in part 2, however, was the chronic obstructive pulmonary disease, hypertension. Next, another case here would be again presented to a primary care physician, 34-year-old female with no significant medical history. And on examination, there were these other symptoms detected as conditions, and they were admitted to hospital. CT scan, respiratory specimens tested, and it was PCR confirmed as COVID-19. Deteriorated, developed ARDS, and despite aggressive resuscitation, expired on hospital day 4. Next. What we see here is ARDS, the acute respiratory distress syndrome, was the immediate cause of death. This was due to pneumonia, which was due to COVID-19. Now notice again in this case, what do you see here that is missing next to that COVID-19? The test result. Yeah, they didn't say laboratory confirmed or suspect or clinical, etc. Although we know in the case, we see in the case notes that it was confirmed, but it needed actually to go on the death certificate, because you have to remember the coder is not seeing the case notes very often. They're in different positions. Sometimes if they're in the hospital and their coders are in the hospital, then they will see the PCR results. However, in many scenarios, the coder is not in the hospital and does not have access to the medical records. And so you need to actually specify whether it was laboratory confirmed or suspect. Next. The example, another example here, again, type 1 respiratory failure, which was due to bronchopneumonia, COVID-19 confirmed. Next. First, with respect, let's go back one, yeah. With respect to our coders, we see here, so a sequence is terminating in the first condition, so we're using a general principle A. Yeah. So it's straightforward here. The underlying cause is COVID-19. Next. Again, we have another example here. We have acute respiratory distress syndrome, which was due to COVID-19, and pneumonia, same line, and hypertension, due to hypertension. So straight away, we see something is very strange there, because this certificate is telling us hypertension led to COVID-19 and pneumonia, which led to acute respiratory distress syndrome. And then we've already said, and we know that COVID-19 doesn't have any conditions in this due to position. So hypertension cannot cause COVID-19. Next. So these are the two things here that we take note of. Next. Oh, sorry, can you just go back one? Let me just go to the coder's side. So again here, we can't use general principle because there's not one condition on each line to my coders, and neither general principle B. So we go to the next one, and then we see therefore our underlying cause is U07, the COVID-19. Yeah, next. In this situation, just given an example where the time hasn't actually been entered. Yeah, just an example. Next. Again, another example where HIV disease has been put in the due to position of COVID-19. And next, really and truly, HIV should be going in the part 2. Next. Again, a few more examples here again of a COVID-19 case. And again, we've put in the part 2 hypertension, 10 years, diabetes mellitus, 15 years. These are conditions that would deem to exacerbate or contribute to the final death of the patient. But again, the final underlying cause here is COVID-19. We're putting those comorbidities in the part 2. Next. Another example. Again, I'm showing, pointing out to you two the time frames. You're seeing the 30 minutes, the 2 days, the 2 years, etc. And then the history being given in terms of the other conditions that the physician also felt contributed. And sometimes we see a lot of things mentioned here because we also tell the physicians to detail, on the side of details. So they've identified a number of conditions, comorbidity conditions that may actually have contributed or and exacerbated the situation. Next. Oh, just going back once again. Sorry, Brenda. I just wanted to point out in this case here that this was another example where though the person did have COVID-19 laboratory confirmed, note it was 17 days ago, the physician still has felt that it was not a COVID-19 death. And so the underlying cause here is a coronary arteriosclerosis. Next. Just want to point out that indicating that the person is pregnant is important, of course, but also to our coders is that even though it's a COVID-19 death, we're still going to use the O codes for pregnancy. Yes, and so we're using, and then what you can put at the side is identify for the purpose of record is to actually put the code, the respiratory failure code, which would be the J960. And in terms of pneumonia, the J118. And of course, the COVID-19 code. Yeah. But the actual underlying cause of death here would be the 0985. And of course, additionally, you can put, if depending on the type of system that you have for recording of information, the U071, but it's really other viral disease complicating pregnancy, childbirth, and the puerperium. Puerperium. So it's an 0985 code that you're going to be using, not the U071 in this case. Next. Again, another example of a non-COVID death, but with COVID diagnosis condition. Next. Another, and in terms of motor vehicle accident here, I'm just making a note that again, in the manner of death, which is in another part of the certificate, remember to put in the exact kind of the of manner of death in terms of the accident and any other external cause. Next. Okay, some last coming up to the end now, some cause of death reporting reminders. Next. We want to avoid abbreviations as much as possible. And I'm giving some examples here. Unless we go down to the MI, myocardial infarction. For the coders, it could be also mitral incompetence. They are not physicians to understand the other conditions that are on the page, which one is being spoken about. Very often, some of the older ones or the more seasoned coders may know, but other than that, we really would prefer if you don't use the abbreviations. Acute diarrhea, for example, was that Alzheimer's, dementia. You'd be surprised. A lot of people do use abbreviations, and so you may not use an abbreviation for Alzheimer's and dementia, but somebody else may be using the AD also. And likewise, other examples that are given there. But then again, please note, as Vilma did identify, that for COVID-19, the WHO has deemed it acceptable to use the abbreviation for that particular condition. So in that case, an exception has been made. In terms of avoiding the short form too, again, for there not to be any ambiguity, because CABR could be cancer of breast and for some cancer of the brain. So again, we would really prefer not to use the short forms. Next. And again, avoid terms such as, as we use all these old age and senility, etc. Try to avoid them. I know to a certain extent that nothing else comes to mind, depending on especially if you're a physician who deals a lot with old people's homes, and you've been called out for a person that you have absolutely no history or nothing about, but it really cannot be the immediate cause of death. There may be one or two conditions that have been due to old age, and thus the etiological sequence should be specified. If old age was a contributory factor, put it in part 2. Yes, so this is just an example here where don't put bedridden. Put, something about aspiration, pneumonia, or old age. You want to imply that was it a stroke, and put the things, put it in part 2, like the old age or the hypertension, if you want to, to actually be more specific. Next. Final slide. Just a general reminders. Have to put in that plug for legible writing. It really is very important. It helps for a number of reasons, which I'm sure you would understand. But we really would like to have more legible writing on the medical certificate of death. Avoid abbreviations we talked about. Duration is important. Where you know it, you can put approximate, you can put 3 to 4 weeks. It all gives us an idea. Record your diagnosis as precisely as possible. Utilize all the reports you have, be it lab, be it autopsy, because there's a lot more I can go into, but we just don't have the time. But putting in, the etiology of the particular bacteria or the name of the virus, etc., are all important. Give information on the disease and the circumstances of any injury. Consider part 1. Remember your logical sequencing, and do not place your underlying cause of death in part 2. And do not report mechanistic terminal events like cardiac arrest, respiratory arrest, ventricular fibrillation. Be a lot more specific, and do not report the symptoms or signs. Next, and that's it. Thank you very much for listening and being so patient.
Yes, Angela, yeah, thank you very much for this very comprehensive presentation. Well, as you were going through the cases, I say, well, at the end of this session, everybody should be able to do it. Thank you very much. So you clearly outlined the step-by-step approach that should be followed to analyze death and conclude that it is due to COVID-19. You illustrated this step by practical examples, which we appreciate. You talked about other concerns to be considered when analyzing mortality due to COVID-19. You reminded us a few things like coders' responsibilities, some do's and don'ts. So it was really a very comprehensive. Thank you very much. So now what we have to do on the agenda is to open the floor for discussion, comments, and questions about the presentation, but also on the WHO guidelines as it comes to COVID-19 mortality coding issues. So what I want you to caution is that we only have 15 minutes for this question and answer session. I want everybody who wants to make a comment or ask a question to be very precise and to the point, so that we can give a chance to everyone who wants to communicate the time to do so. So the floor is open. Anyone who wants to take the mic, or you can also write your question or your comment on the chat, and we'll be able to give you a feedback. The floor is open.
Okay, there's Adeline Vanterpool. Her hand is up. Do you want to have the mic? I can open your mic for you. Go right ahead.
I was actually saying earlier I couldn't hear clearly what the lady was presenting. She was breaking up, but we were following the slides. That's all. And secondly, we have a system in the BVI, Chris, an electronic database where we go in and enter the death notification. That system would not allow us to skip the part D, the underline, to leave it blank. And it would not allow us to use certain words like positive and confirmed.
Understood.
I spoke to you about that already, VOS system, when you were in
Yes, that's true. Yeah, well, yeah, they would have to therefore call in and get that additional information to know exactly how to code it.
Okay.
Yes.
Thank you.
Noted.
More comments, questions? The floor is open. Brenda, do you see?
Wow, apparently we were real clear.
Well, I think it was very clear.
Spoke too much.
Yeah,
Anything on the chat?
No, I don't see anything in chat, and there's no right now.
And there is no hand up.
No, not right now.
Well, persons are free to, as they mull over things or as situations do occur, to, send us a note, and we'll be happy to answer them, because I know that probably a lot of people have not come across the certified COVID deaths, because our numbers in at least English speaking to the and the Dutch are smaller, especially in the OECS region. So I could understand.
Yeah, maybe while
I think I see a message that I'm breaking up. Am I?
No, we can hear you quite well. There
Hearing you clearly. Okay.
Yes, there is a question. Are there any local coding courses in the region?
Vilma?
The question is, we can't hear you. The question is, are there any local coding courses in the region?
We have Parro Reis and also Capfa Reis. I will put in the chat the link for the Parro virtual course on properly completing that certificate. And I think Jean-Marie will also send the link for the recording, where I hope my voice sometimes, who cannot hear me well, maybe in the recording. But I will include the link for the course. Thank you.
Yes, with respect to actual coding itself, we have a few what we'll call recordings of trainings, but we don't have an actual formal training in terms of how to actually code. I'm not talking about how to complete the death certificate, but how to actually code. And then with our movement to ICD 11, we are looking at actually formalizing and having a more formal, and I think Vilma would agree with us, with me here, in terms of how we're going to approach, WHO is doing a lot of work with respect to how to approach the training of coding using the ICD 11, because that is in essence where we are moving to in the region.
Okay, we have another question. Should medical officers enter multi-organ failure on the death certificate? Did you hear, anyone heard the question?
Oh, yes. Oh, I wasn't sure if Vilma had wanted to answer that. Yes, they can put multiple organ failure, but we definitely do want to have some sequence of events that led to it, but yes.
Okay, there is
Don't know if Vilma, you wanted to add anything to that? I think your mic is muted if you're talking.
No, I completely agree with you about this question.
Just missed me call and I wasn't there, so I must tell them we're giving them up free, so I have to cancel the invoice.
Yeah, Brenda, is there any other question?
How the acting CEO tell us to waive them
okay,
up?
there's just
Nothing.
there's just a comment. Someone, well, yeah. ICD 11 alphanumeric, when that becomes available,
Yes.
can you please be notified?
Of course, it will be the whole region, but yeah, they will be notified. And we'll probably have more than one training too on that, because it's a very huge move and it requires a lot of thought. It's going to be, it's a lot more precise and a lot exact. And therefore, again, we're going to be depending on our physicians to really be, detailed and accurate in their recording of information, both from a medical record perspective in terms of morbidity coding, as well as from the mortality side of things in terms of the medical certificate of death completion. Yes, so yes, we definitely will. I think Jean-Marie too, we'll be working together for when these trainings come out, so that all who need to know will know and be able to participate.
I'll be available to work with you, Angela, as you know.
Of course.
Again, there's some questions pertaining to the availability of the presentations, and yes, they'll be made available to everyone. We do have the contact information for everyone who registered for the course, so we'll send you the presentation and the recording.
Okay, that's good information. Yeah, anything else on the chat or any hands up? Are we done, Brenda?
Yes, my hand is up.
Okay, please go ahead.
I have a question for Ms. Hines. In regards to the multi-organ failure, so we can use it as the immediate, but you have to put like the sequence leading up to it, because a lot of times the doctors say the immediate.
I know, because you see, multi-organ failure will be one could argue sometimes it's a cop-out. I don't want to use the word cop-out there, but meaning, you know, it is what it is. It is a multi-organ failure, and you don't want to go and list all the whole long list. But usually there's a sequence of events which is what we want them to put. You know, there's some initial sequence that started to lead to that multi-organ failure, and so we want to see at least a couple lines showing that sequence of events.
Thank you.
Because that will guide in understanding, you know, where it was coming from, what the conditions, what led to.
Understood. Thank you.
Okay, so it's 1:15 p.m. I'm going to allow 1 or 2 questions. Is there any burning question that we need to ask at this point? If not, I'm going to close the meeting. Any burning question?
No question. Excellent presentation.
Okay. All right.
Thank you.
All right. So really, I want to thank Pao and Kalfa colleagues for facilitating this meeting. I think it was very useful in terms of the information shared. I also want to thank the country representatives. You are the ones really who are driving the response on the ground, and these guidelines were meant to help you to do your job. So the guidelines are available. The presentation will be shared. But if you need to reach out to us for any further clarification beyond what was presented today, you know how to reach us. You can either call me or send me an email. You can write to Angela. You can write to Vilma or any other colleagues. So thanks everyone for participating. I think it was a very good meeting. You have a good afternoon. Bye-bye.
Thank you, and you too. Bye-bye.
Okay, everyone. Then. Bye. Thank you.
Bye-bye. Thank you.
Bye, Ms. Hines. Bye, everyone.
Much.